Everybody, I'm Leah Lindak. I'm one of the oncology genetic counselors at the Traditional Cancer Institute. And today we're going to be talking about hereditary cancers and the ins and outs of genetic testing. And this is part of a genetic series that I believe will be going on for a couple of months with TriHealth. So it looks like we have a couple people on the WebEx, and then of course yourself. So feel free to ask questions as I'm going through it. Just stop me and interrupt me, we'll talk through it, any questions you might have. Or if you're more comfortable writing it in the chat, that's absolutely fine for the people on WebEx. So it's not working. Oh, there we go, okay. So for the outline for today's presentation, we're going to talk a little bit about first, just a basic genetics background. And then we're going to talk more about what a typical genetic counseling appointment looks like, and also who is appropriate for testing, so why we get referrals, what we talk to them about during a session, and then what genetic testing can tell a patient and what it can tell their family, and some of the risks and benefits with that. Next, we're also going to go through some of the more common questions I get from my patients. So what's this going to cost me? Does insurance cover it? And then what are some protections they have in place for them as well? So first, when I usually tell people I'm a genetic counselor, if they've never seen one, they usually give me kind of a wide-eyed look. So a genetic counselor is someone that's trained specifically to test for and counsel on inherited conditions. So we all have a master's degree from one of the accredited programs in the US. We then take a board exam, and we also have state licensure. And really what we are meant to do is facilitate testing for patients, and then we communicate those results, because they can sometimes be kind of complex, with providers and patients. And then we also guide them on next steps, so what we should be doing for proper medical management moving forward based on those genetic results. So this is just kind of an umbrella of some of the different specialties within genetics, or within genetic counseling. So on the left here, you're going to see some of the bigger specialties. So prenatal, where we're focused on reproduction and family planning; cardiology, focused on the heart; oncology, that's what I do, different cancer predisposition syndromes; and then of course pediatrics, which is focused on more childhood onset conditions. And then if we look at the right side, those are more the subspecialties. So there's neurology, which is the brain; ophthalmology for the eye conditions; and then there's also laboratory and research genetic counselors too. There we go. So before we jump into hereditary cancer syndromes and what genetic testing is, I just want to do a small genetics background. This will take you right back to like high school biology probably. But basically genes are all of our instructions that we inherit from our parents that determine our genetic makeup. So they can determine things such as traits like the eye color you have, how tall you are, your hair color, but it can also influence things such as health and personality even. And it's important to mention that genes can have alterations that aren't always harmful. It's very normal to have alterations within our genes, but there are some harmful alterations, or mutations as we usually call them. And there's two different kinds. So one is inherited. So this would be a mutation that you inherited from your parents at birth, or when the embryo formed. And then there's also acquired mutations. And this is important to discuss the difference between the two when we're talking about the genetics of cancer. So the two main points when we're talking about the genetics of cancer is all cancer is genetic, but not all cancer is hereditary. And what I mean by that is, when I say all cancer is genetic, it's because, cancer is formed by mutations that occur in a specific subset of cells. So usually this is just within the tumor itself, not necessarily all the cells in your body. So yes, all cancer is genetic, meaning that it happened from mutations that occurred within the tumor, but those usually do not affect the egg and the sperm cell, which is why it can't be passed on to children. So not all cancer necessarily is hereditary. And actually, if we're looking at this pie chart right here, we're seeing that really only a small subset of cancer is truly hereditary, really only 5 to 10% of it. Where in this dark blue portion, those are the sporadic cases of cancer. So that's around 80% of cancers are truly due to just mutations that we pick up throughout our lifetime. And those are usually, those sporadic mutations are usually due to environment, the food we eat, the air we breathe, As we get older, our cells just tend to mutate at increased frequencies, so that can lead to increased risk for cancer. But very rarely is it truly due to an inherited mutation that has been passed down from one of our parents. And can you see my cursor up here? No? Oh well, that's okay. So that's what brings us into what we focus on as genetic counselors, the hereditary cancers. Now, most providers are taught when you hear hooves, think of horses before zebras, and that's really important because you wouldn't want to think every stomach ache is something detrimental. But there are a small portion of providers, genetic counselors, that need to be on the lookout for that very rare chance that if we hear hooves outside, it's actually going to be a zebra. And those are those rare hereditary conditions. So normally, when we see a patient, or they're referred to us, or they call in and they just want to know more about their family history of cancer, we often sit down with them and we go over their personal and family history of cancer, and then we really dive in deep and ask follow-up questions. We get a really detailed family history, and we'll actually look at some of those pedigree examples in a couple of slides. And then we talk about the option of genetic testing. And I always tell a patient, yes, you may have been referred to genetics, but it doesn't mean you have to do genetic testing. It's definitely up to you. It's a person's personal choice. And also, if a person doesn't technically qualify under our criteria for genetic testing, I'll still help them get access to that information because I'm not the gatekeeper of their genetic information. So yes, we use some criteria that helps get insurance coverage, but really there are still some affordable options even if a patient just wants to know more about their personal risk. And then after that, I help them just make a decision. Do you want to test? How many genes do we want to look at? What can it tell us and what it can't? Okay. So diving more into that personal medical history, so this would usually be when a person is referred due to a personal history of cancer, but not always. And certain diagnoses trigger a referral to genetics immediately. So that would be something like ovarian cancer or pancreatic cancer. Those are just a few of them. But you can also have an age of diagnosis that triggers a referral. So that would be something like breast cancer at 45 or colon cancer at 50 or younger. That would qualify a person immediately for genetic testing. And then even if a person does not have a personal history of cancer, there can be other findings that signal to us that maybe we need to look a little bit more into it. So certain skin findings, you can have a large number of polyps at a younger age, and usually that's like 10 or 20 polyps in a person's lifetime. That's more than what the general population sees. And then even certain eye findings can trigger a genetics referral. Now, when we're looking at the family history, we talk a lot about red flags within a family history, and some of them are going to overlap with that personal history. So one of the big features we look for are multiple generations affected, and usually with certain patterns of cancer. So when we're seeing things like a family history of breast, ovarian, and prostate cancer, that can signal to us that a gene called BRCA1 or BRCA2 may be mutated in a family. Or if we're seeing things such as colon cancer, uterine cancer, and ovarian cancer, that can trigger a certain hereditary colon cancer syndrome that we would want to test for. And then again, young ages of diagnosis or specific diagnoses like the family history of pancreatic cancer. But young age, like if you see a child, let's say, and as hard as it is to deal with, sometimes you can see a child in a family history diagnosed with leukemia at a very young age. Even though they were diagnosed in childhood, that doesn't always mean that it's going to be inherited. Those are often something that just happens by chance. So it's important to talk to a genetic counselor to see what their risk assessment is and to see what ages are concerning and what diagnoses are concerning. Even ancestry, that can qualify a person for genetic testing. So if somebody has, for example, a family history of Ashkenazi Jewish descent, that would immediately qualify them for genetic testing because we know people of Ashkenazi Jewish descent have an increased chance to test positive for one of the breast cancer predisposition genes, and so we would definitely want to see them for that. And then even limited family structure or information. on one or both sides of the family history can qualify a person. So if someone was adopted, or if they simply just don't know anything about dad's side, for example, we can still use that as criteria to justify or warrant genetic testing. So now we can go into two different examples of pedigrees. And this is what a pedigree would normally look like for one of our sessions. So 1 and 2, they have the same structure. And our patient is, you can't use my, can I point? Can you see me there?
Sure.
Okay, so our patient is here with the little arrow. And that signifies that it's our proband, or the person that we're focused on. She is coming in pedigree 1 for a family history of cancer. And if we look on the left side, you're seeing her dad's side, and then on the right side, you're seeing her mom's side. So if we go up 2 generations, you'll see her paternal grandfather has prostate cancer at 82, and then if we look at her mom's side, we'll see her maternal grandfather has lung cancer at 75, and her maternal grandmother had basal cell carcinoma on her shoulder, I believe at 62. And then down a generation, we'll see her maternal aunt, or her mom's sister, had cervical cancer at 30. So to her, she's coming in with 4 different family members diagnosed with cancer, and she wants to know more about her risk and if she should have testing. In this case, if we start first with that paternal grandfather who has prostate cancer, it's not metastatic. That's a follow-up question we often ask our patients, making it less likely that it's hereditary. And it's occurring in an older gentleman, and that's fairly common. So nothing too concerning for dad's side. Dad had 2 polyps on colonoscopy. That's pretty normal at 58, so nothing concerning there. Now going over to mom's side, that lung cancer in an older gentleman who had a history of smoking, we can most likely attribute that diagnosis to his past history of smoking. And that basal cell, that's also a very common skin cancer that can be diagnosed, usually due to sun exposure, and it's proving that it's on a sun-exposed area of the body. That's pretty common as well. Now, going down to the maternal aunt who had cervical cancer, and this one is at a younger age, so that's one of those key features we look for, but cervical cancer is usually due to a past HPV infection, which would be something environmental or acquired mutations, rather than something that would have been inherited. So for this patient, I would tell her, hey, you absolutely can get genetic testing if you're interested, although my suspicion is very low. There's nothing that is sticking out to me, or there's no specific syndromes that I'm suspicious of here. So I would give her that option, see if she'd want to test still, but otherwise, she could probably go on with normal population screening and be totally fine. Now compare this to the second patient. She's also 32 years old, but she's coming in with, on her dad's side, same history as in patient 1, so just prostate cancer in an older paternal grandfather. But on mom's side, now we're seeing multiple generations affected with a specific pattern that is concerning to me. So here we see melanoma in the maternal grandmother at 62. Now when you compare melanoma to basal cell, melanoma is more often hereditary compared to basal cell. So that's one little suspicion I have. Additionally, her paternal uncle had pancreatic cancer at 60. Now, usually you have to have a first-degree relative with pancreatic cancer diagnosed to qualify you for genetic testing immediately, but because she already has an aunt with ovarian as well, so the aunt with ovarian, the uncle with prostate, and then the grandma with melanoma, that would qualify her for genetic testing. You actually only need one close relative diagnosed with ovarian cancer to qualify you for genetic testing. So for this patient, it would be a good option. But the next thing to mention is the best person to test here would actually be the uncle or the aunt or even the grandma, because testing the person that's affected is going to give you the highest chance to actually find a mutation in the family versus someone 2 generations down who's healthy and unaffected. Let's say she's not close to her aunt and uncle, or they're not interested in testing, that's okay. The next person I'd want to test is her mother. She would be the next best person, because if we can prove that her mom has a mutation that is causing that family history of cancer, then we would know exactly what to test the patient for. And if the mom is negative, then we know that she passed on all working copies of those genes to the patient, and we don't even need to test her. Any questions there?
What if you don't have those generations to work from?
And that's okay. Sometimes you don't have the information. Do you mean like if you just didn't have,
Yeah.
like anyone available to test?
Yeah, I mean, like, my mom is
Yeah.
deceased, so, I don't know who else we would test on next.
You would be the next best person. So if this case we didn't have the mom to test or we didn't have any of the affected family members, we would go then down to the patient or the proband in that case. The tough thing with that is if we can prove that this person gets genetic testing and she's negative, it doesn't tell me if there was a mutation in the family that maybe she just didn't inherit. So it kind of leaves a little bit of a question mark still. Now, if we were to find a mutation, that would probably give us the answer to why she has that maternal family history of cancer. But it's more likely than not to be negative because if we know, most cancer is sporadic or just acquired. But no, good question. We would definitely test you in that situation. Okay. Now these are two more quick examples just to show you that you don't need a crazy family history of cancer or very colorful family history to still warrant you for testing. So up here in Pedigree 3, we're seeing this patient was diagnosed with breast cancer at 40 years old. So that's a very young age of diagnosis that immediately would qualify her for testing. And then in Pedigree 4, we're seeing that this patient had a maternal aunt with ovarian cancer, but they're not available to test. So in that case, we'd want to move over to either the mom or the patient in this case. So we've been talking about genetic testing, but now I want to get into more of the details of it, what it is, how many genes we can look at, the types of results, insurance coverage, and all of that. So when I talk about genetic testing, what we're actually looking for are cancer predisposition genes. Now, I'm not testing a patient to see if they have these genes, because I know they have all of them. We all have them in this room, 2 copies of them, because you get one from mom and one from dad. And over here on the right is actually a chart that I often show my patients that can show the difference in panel sizes or how many genes we can look at one time. So it starts over on the left, and it's some of the breast genes, colon genes, pancreatic genes, and it moves all the way over to a very large comprehensive panel, which is 77 different genes, and we can even go out to 91 if a patient is interested or if we think it's reasonable. It just depends on what the family history and personal history is showing us. So again, I'm not testing to see if they have these genes. I know they have 2 copies, but I want to see, are they working properly in the body? I want to see if they are protecting this person against cancer the way that they should be, because normally these are cancer-fighting genes. And if we can identify a mutation, then we can better help tell them their cancer risks. So we do that through, first, we get a DNA sample. Often it's blood. With blood, we could look at both DNA and RNA, which does an even deeper dive into the genetic information. We can also do saliva if a person is, very uncomfortable with a blood draw, or we can even do a cheek swab or sometimes a skin punch if necessary. And what that is going to do is we send that to the lab, and they're able to read through the genetic code and see if all of the letters or colors in this example are matched up properly, and if the gene is written properly so that it's producing a protein product. That protein product is what's actually expressed and shown to our cells and tells them how to grow, divide, and when to die when they should be. If you do not have that protein product available to the cells, it's essentially taking those instructions away, and that is what can lead to abnormal cell development or cell growth. They could be living longer than they should be, which could increase risk for a tumor or a cancer. And that's shown here. So if we're looking at this last slide, we see green and red match up every single time, and that's truly how it works. 2 letters match up every single time down this genetic sequence. In this case, a person has a mutation. So now yellow is trying to match up with red, and it does not work. The body does not know how to read that sequence. It pushes everything downstream out of sequence or out of the way, essentially, and that protein product that should have been produced and expressed to the cells is no longer there. And so that puts a person at increased risk for cancer. And here's how that kind of works. So this is a person with a cancer predisposition syndrome up top in the blue. This is how every cell in her body looks. She has one working copy of a gene, We can use BRCA1, for example. Have you familiar with BRCA1? That's okay. So that is one of the more common hereditary causes of breast and ovarian cancer. Everybody has this gene, 2 copies, and this woman in particular has one working copy in the black, and she inherited a mutated or non-working copy in the blue. Now that alone does not give her cancer. She's not going to be born with cancer because of that, but it puts her at an increased risk compared to the general population down here at the bottom. And that's because all she has to do is acquire a second mutation to that working copy of BRCA1. Now, both copies of BRCA1 are taken out, and that's what could lead to an early age of diagnosis, such as breast cancer or ovarian cancer in a woman, and maybe prostate cancer in a man if he carried a BRCA1 mutation. Now, being born with a cancer predisposition syndrome does not mean you are going to get cancer for certain. It just makes it more likely than the general population. Because this woman down here, yes, she can still get breast cancer, but it may be later in life or never at all because she has to acquire 2 mutations rather than being born with a predisposition in the first place.
How do you acquire them?
So acquiring a mutation can happen through different carcinogens. Like if you were to smoke for a long time, that's what increases mutation rate in the lung cells. But as we age, our cells can just by chance mutate. And that's sometimes what they want to do as we get older. That's why it's important to also live a healthy lifestyle that can decrease the chance of acquiring sporadic mutations. Okay? So even with a person with a predisposition, we tell them, there are still ways to continue reducing that cancer risk, but one of them is to make sure we're increasing screening, but also balancing that with a really healthy lifestyle too. Okay. Now, if we can prove then that a woman, in this case, has a mutation, we know then what the risks to siblings, parents, and children would be also. So we know that she inherited it most likely from one of her parents, so her parents would have a 50% chance. All siblings would have a 50% chance to have any mutation that she's positive for, and her children would also have a 50% chance. So, and that's just because it's a flip of a coin. If it's either in the egg cell, the mutated copy, or if the working copy is in the egg cell, which one she passes down. Okay. Now this is just an example of how we can change screening for gene-positive patients. So when you first do that genetic testing, and let's say I call you and I say, hey, we found a positive result, it's then going to depend on which gene is mutated to determine what we're going to do in terms of your screening. So for that BRCA1 gene, like we were talking about before in the example, we may increase breast screening, so maybe doing MRIs and mammograms earlier than the general population. And then for ovarian screening, there's a blood test we can do. Sometimes we can do an ultrasound, but often they'll recommend removal of the ovaries after a woman is done with childbearing to reduce that risk down as low as possible. So there are some screening methods and there are some prophylactic procedures that are available.
It's still so hard to get doctors to do that procedure. I know for a while it was hard to get a doctor that would do it.
So they balance it out depending on which mutation is present. So if it's a very high risk for ovarian cancer and it's going to benefit a person to remove the ovaries, because there are some benefits to having the hormones expressed from the ovaries throughout a woman's life, but if the risk for ovarian cancer is far outweighing that, then they'll definitely take that into consideration. And of course, I'm not a gynecologist or a surgeon or anything like that, but they do look at a patient's full story before determining what surgery is most appropriate. But I do know for at least BRCA1 and 2, it's recommended to have, the ovaries removed after 40, 45. And then for here, this would be a male that's positive for BRCA1. We would do things like increasing prostate cancer screening at 40 rather than 50. Those are just examples. We also do have them go to the dermatologist once a year, increase pancreatic screening if they do have a family history of pancreatic cancer. And we also increase male breast risk because there is a small risk for male breast cancer as well with a BRCA1 and 2 mutation.
So there is a screening just for pancreatic cancer?
Yeah, so sometimes they can do an MRI annually that gets a good look at the pancreas. Other times it's like a scope down the throat with an ultrasound on the end of it that can get a look at the pancreas. That's an option too. Usually we refer to a medical oncologist for a person who has a family history of pancreatic cancer.
But only if they have the gene?
Not necessarily. So there are some cases where it's still warranted to do increased screening even with a completely negative test. Now, if a person had a different gene mutated, such as the MLH1 gene, that's a gene that's associated with hereditary colon cancers. So for that, we would have a person come in for colonoscopies much, much younger than the general population, so usually starting in their 20s rather than waiting till 45. And then for a woman that's positive, not only would we increase her colonoscopy screening, we would also increase uterine and ovarian screening too. So it's usually I tell patients we have to kind of wait to see what we find first to talk about specific screening if we don't have anything that we're really strongly suspicious of at our initial appointment. So just to summarize, for a positive patient who's affected with cancer, a positive test can give them an answer to their diagnosis. It also can sometimes give them treatment options and help surgical decision up front. So if a woman is going to have a lumpectomy, which is just the portion with the cancer in the breast removed, or if they're going to have a bilateral mastectomy, which is removing all of the breast tissue. That can help. Genetics can sometimes help determine what route they take. It also helps identify what other family members need to be tested. And so for an unaffected person that's positive, this may open the door for increased screening, which helps us be preventative for them rather than reacting to a diagnosis down the road. And again, this is that really small piece of the pie, that 5 to 10% of the time we're truly finding a mutation in a family that's increasing cancer risk. If a patient is negative, on the flip side, if they're affected with cancer and then they get a totally negative test, I always tell them this makes it a lot less likely that it's hereditary, but it doesn't completely eliminate the chance that this could be inherited cancer. And that's because we don't know of every gene that's associated with cancer, and so we still have to be a little bit on the lookout for other family members. And we still want to have family members reporting that their family member was diagnosed and they've had negative testing, because there is this piece of the pie that we haven't talked about yet, the familial cases, which there could be multiple genes interacting at one time that can increase cancer risk within a family, even with a negative test. Families often share environments, which could increase cancer risk, and so sometimes we still want to have them come in for increased screening. And then for an unaffected person that has a totally negative test, yes, we talked about how increased screening may still be needed, but we also want to test other family members, especially ones who have been affected, because that could mean that we could find a mutation that that patient is truly negative for, and then they would be off the hook for increased cancer screening, because we would have proven that there is an inherited mutation in the family and that patient truly did not inherit it, and they do not need increased screening then for cancer. It's very case dependent, but that's why we have them come in and talk to us. This is just to show how it can be beneficial. Sometimes I have patients come in and we'll have both of their parents test, and when we can prove that both of their parents are negative, we don't even need to test the child, because we've proven that both parents have 2 working copies of the gene, and that's all they had to pass on to the children, so it's really helpful information for them. So this would be a totally negative case. So the last result you can get, we talked about positive, we talked about negative. The last result you can get is an uncertain result. And that's a little bit frustrating for some of my patients, but we always talk it through. This is called a VUS. And this means that we found a change in the gene, but we don't know enough about it at the moment to determine, is it harmful in the body or is it totally benign in the body? More often than not, about 50 to 90% of the time, those uncertain results are actually going to get downgraded to benign as time moves on, and we gather more data on that specific variant. So if we were to have an uncertain variant found, and then we find it in 100 healthy individuals, that's a really good indication to us this actually is a normal change within the gene, and it is not altering the function of that protein. But if we, in the next couple of years, find it in 50 individuals with breast cancer, that makes us a little more suspicious that this could be harmful in the body, and we may upgrade it to pathogenic. So we have to call it uncertain for now. We don't act on it. We don't change their screening. We don't test other family members. But we will call them and update them even years from now if it ever does change.
How many, like, what percentage would you say of your results are the VUS?
We do get quite a few VUSs. So I wouldn't say a patient in particular gets a ton, like they don't get 10, or 12 of them, but most of my patients at least usually get 1 or 2. So they're fairly common. Sometimes we have people that have a completely negative test, and that's a little more easier of a result to talk about. But yeah, they are pretty common. But I will say we do have a lot of reclassifications where we're calling them back maybe 2 or 3 years down the road, and we said, hey, we found more data, or the lab found more data on this. They're determining that it's benign. No need to worry about it anymore. Now, one of the bigger questions for my patients are, what is this going to cost me? Because, of course, nobody's going to pay, thousands of dollars. They don't want to pay thousands of dollars for genetic testing, and they shouldn't have to. This is something that should be accessible to the general population. So the first thing that I do is I use national criteria that helps justify whether a patient's insurance would cover genetic testing. Things like that can be the criteria we're talking about with the young ages of diagnosis, specific diagnoses like pancreatic and ovarian. I use that in the clinic note to then prove to the insurance company, hey, this person needs testing, you should cover it. But of course, that doesn't always happen. And in this case, a lot of the labs that we use actually offer a direct patient pay, and this is usually around $250, where that is the most that I can reassure patients that they're going to be charged, which is usually pretty attainable. Additionally, a lot of our labs offer some benefits such as free familial testing. So if a person were to test positive, we then know their children have a 50% risk or their siblings have a 50% risk. Blood relatives can get free testing for 3 months after their results are available. So that's something that's really helped our patients identify if they're positive or negative. Okay. And then lastly, we have some insurance protections. So GINA is a law that was signed into effect in about 2008, I believe. And it's the Genetic Information Non-Discrimination Act. So this prohibits private insurance companies from using genetic information against a patient. So they can't use it as a pre-existing condition, they can't raise their rates, and they can't drop them if they're positive. They'll likely have to know that they're gene positive so that they can increase, their cancer screening, but they can't use it against them. Now, this does have exceptions. If a person is in the military, they have a different law which protects them. Or if, for example, a patient works for a company of 15 people or less, that can kind of alter whether or not they're protected by this law. And of course, there are other policies that can still discriminate, such as life insurance, long-term care, and disability insurance. And of course, in the future, we hope we'll have policies and laws that will help protect patients. But as of right now, GINA is our main protection for our patients.
So if you pay for the test yourself, does the insurance company have to get notified of the results if you're paying?
Well, if you're positive, they'll likely have to know because they'll say, well, why do you need colonoscopies every 2 years compared to the average population who needs it every 5 to 10? Or why do you need a breast MRI versus just a mammogram? Because we're going to want them to have coverage for those screenings, so they likely will have to know, but that doesn't necessarily mean that they cannot charge you more just because you're positive.
And I'm sure Medicare doesn't cover any of this.
Not necessarily. So Medicare, at least the labs that we use, and I don't know a lot of the ins and outs about how the insurance works, but I know that some of our labs don't balance bill Medicare, so some of our patients never see a bill if they have Medicare coverage. So that is the majority of the information I had to cover today. Now, if a person had any concerns with their family history, they wanted to talk to a genetic counselor more about genetic testing, this is the TriHealth genetic scheduling number. It's 513-853-4363. You don't need a referral from your primary care physician or a provider necessarily to come talk to a genetic counselor, but we'd be more than happy to answer some of your questions. Now, was there any questions from anyone on the WebEx? I don't know if there's anyone on the WebEx. I see the chat's not. But otherwise, thank you so much for listening, and I'm more than happy to stay over and chat.
Since you filmed it, is it gonna, can we get a link of this that we can watch later?
It'll be on the club website.
Will it? Okay.
Yeah, it'll be
Is that
on the YouTube channel, the club's YouTube
Got
channel.
it, okay. I have a whole family of medical people that will understand everything you're talking about, and I'm
Very
like
good.
the autistic person, and I'm like, I could never repeat any of this. I'd rather just have them watch the link.
Sure.
And see what they think.
Absolutely.
Well, my family, my mom,
Mm-hmm.
died of pancreatic cancer when she was 73, and then my cousin on her side of the family, her first cousin, son, died of it when he was in his 40s, I believe.
Oh, wow.
But
You
that's
see-
all on her side of the family.
Yeah, you absolutely would qualify.
But I think just, I mean, at 64, things are popping up in my medical history, and I think I'm just wired more like my dad. I think I got all of his genetic predisposition, and my sister's got my mom's side, but, I mean, I'm sure that is no indicator. You know, I can-
Yeah, you can look or act more like one parent, but truthfully, it is that flip of a coin or 50-50, which gene was passed on from each parent. So it would be a good idea to, at least come in and chat with us. And of course, after you meet with us and you're like, you know what, this is not for me, you do not have to move forward with testing, but at least you'll have more specific information to your family history.
Okay. Because, I mean, you started mentioning something about the polyps and
Yeah.
and the skin cancers, and my dad kind of dealt with a lot of that stuff, and so I'm like, well, I've kind of got stuff on both sides, so.
Yeah, and some of those are going to be typical, aging things that pop up. Sometimes a polyp or two, as long as we're catching them early enough, which is why it's so important to get those colonoscopies, they're manageable. But other times we have a polyp burden that's just, abnormal compared to the general population. And so for those cases, we want to look more into it and make sure it's nothing that they're born with that's potentially causing that abnormal growth.
And you may not know how to answer this,
Mhm.
but how do you feel about the Cologuard versus a traditional colonoscopy?
So for people that are at average population risk, the Cologuard is a good option. But for anybody that's at increased risk, if they have a family history of colon cancer, or if they have a large number of polyps, the colonoscopy screening is better.
I don't really know, my dad's deceased, and
Mhm.
he died, he lived to be 90, but I
Oh,
know he
very-
had some issues with polyps
Mhm.
during colonoscopies, but I don't know how many and
Yeah.
whether it was later in life, but, I mean, we never had a history of family history of colon cancer, but I went in for a traditional colonoscopy a couple years ago, and I stopped breathing in the middle of it. So I'm terrified to ever go back for another.
Understandable.
I'm
Yeah.
like, no. And so I did Cologuard last time, and my doctor's like, I'm okay with that as long as nothing kind of looks suspicious.
And that's one of the reasons genetic testing can kind of help. If we can look at all those hereditary causes of colon cancer and prove that, rule them out in you, then maybe Cologuard is a good option for you. You have no family history of colon cancer, you are doing some sort of screening, and we have negative tests. That's a better indication that Cologuard may be a good option for you.
You mentioned when you do the genetic testing, you test certain genes.
Mm-hmm.
How do you know how many to test, and is
Yeah.
is the test based on how many you test, or?
So part of it is based on our analysis of their personal and family history. And part of it is also based on the patient's comfort level. So some people like to stay very targeted. If they only have a family history of breast cancer, then we may only look at, this looks like it might die. I don't know if it'll shut off.
Okay.
So it kind of depends on their comfort level and how many genes they want to look at. If someone's here and they're like, I want to know everything I can about hereditary cancer syndromes, well, then in that case, we'll go to the largest panel we can. But if someone's like, no, I only want to know just exactly what's going to help me right now, then we'll do a smaller panel.
But if you do the full panel, is the cost of the test the same?
It's the same. It's the same amount of blood, the same turnaround time, and the same price. Because what we prove to insurance is that, let's say if there's a family history of breast cancer, I prove to insurance that they need sequencing of BRCA1 and BRCA2. And then after that, it really doesn't matter how many extra genes we add on.
And you said that you can test through swab, is one a better option? Like, does the one give you more information?
So they're both pretty good samples, saliva versus blood. Blood can look at RNA, whereas saliva cannot. And so that's a little bit deeper of a dive. And saliva can sometimes fail. So if a person was eating or drinking within 30 minutes before they collected that sample, there is a chance that it could fail. So sometimes if I know we need to get a reliable sample for a patient, I just send them for a blood draw. But if, like, let's say they're at home and we did a telehealth visit, then I can just send them a saliva kit and they can ship it off to to the lab themselves, and we don't have to have even come in.
I know that there's been some controversy about people that get that genetic testing, about their information going into a database.
Yes.
So how secure are these tests?
So the labs that we use, at least as genetic counselors, they're all something called CAP/CLIA certified. So they have certain certifications where we know that a patient's genetic information is not getting sold or de-identified and used elsewhere. So we make sure to choose labs that are reliable and offer protections for our
So it
patients.
stays private?
Yes.
Okay.
Yeah. And that's part of our consenting process as well.
That will be all I have.
No, you have great questions. This is like, you know exactly what to ask here.
She has two questions I was gonna ask, so there you go.
Yeah, I saw you nodding too. You're like, yes, that one. Did you have any other questions?
No, I was just curious about what your thoughts were on the Cologuard test. I've used it twice.
Now that is better answered by a GI doc. I will say that's just
But
what
it's
I've.
super easy. I mean, the whole prep and everything on the traditional and going.
You get the guy at the UPS store that looks at you when he sees the box.
Oh,
He knows
yeah,
what it
that's
is. He's
true.
like,
Oh,
"Yeah,
I'm
just put
sure
it on
they
the-
do.
Just leave it at the end of the counter.
Oh.
That's true. But, I've actually done it twice now,
Yeah.
and I find it to be very simple, and, it just is not, I mean, I was terrified to ever go back.
Yeah.
Have you done the 23andMe yet?
No.
No? What are your thoughts on that?
So 23andMe is a type of direct-to-consumer testing. Those don't always have the same protections and confidentiality that our labs have. And I think that it can be a good initial test, especially for things like Ancestry, but it's not as comprehensive for health analysis as, the tests that we order.
They kind of send out this kind of sporadic health notes on things
Yeah.
that might be associated with, your genetic findings.
Exactly. And they're looking at very common variants, but they're not reading through the entire sequence of the genes. There could be mutations that they miss, but when a person sees, oh, I'm negative for BRCA1 or 2, they think that they're entirely negative, but they haven't actually looked at the entire gene.
Is 23andMe, is that one of those genetic, or is it just a test for your
What it really was meant for
genealogy?
ancestry.
It can do both.
But it also gives you health.
Yeah.
Oh, it does,
It,
okay.
it does give you some. I mean, there's what you may be a propensity in your,
Mhm.
Gotcha.
your family, that, whatever they found, as you were saying. They may
Yeah.
not be looking at everything, but
But isn't that one of the companies that takes your DNA and puts it into a database?
I think so.
Yeah. I mean, we worried my aunt, my mother's sister, and sadly, my dad only had one brother, one sibling. He's deceased. My mom had 3 siblings. They're all deceased. So nobody in that generation, I mean, is alive anymore.
Yeah.
And we really, really wanted to get my aunt, my mom's sister, to do the genetic,
Yeah.
what do you call it? The
23andMe or the
like
direct
that
consumer?
kind of thing.
Yeah.
And
Ancestry.
She refused to do it because it was going into some humongous database, and she said, I just don't want my information out there. Well, now she's deceased, and we just don't have anybody.
Yeah.
Except my mom's first cousin is still alive, and he is the one whose son died of pancreatic cancer.
Yeah, you could get him. I mean, I would more so for Ancestry. Those are okay tests, but if you wanted to come in for any health related
And he would
information, it's
based
probably
on what you were saying about testing the elders,
Yes.
to see if they passed it down. My uncle, whose son died of pancreatic cancer, who was my mom's cousin,
Mhm.
that's the link on that side of the family. And
Yeah.
I wonder if he, have the mutation.
Yeah, and you could look at that side of your mom's family, and then, of course, you yourself, you'd be the next best person, too,
Right.
to see if there's anything we can find.
Well, I'm really curious now.
Absolutely.
I'm looking for more health issues.
No, of course not. But if there's something you can act on, it can be very helpful for your screening moving forward.
And you mentioned cardiac screening.
Yes, we have a cardio genetic counselor at TriHealth, actually,
Okay.
Annalise Page, and so she would be able to look at the family history more so under the cardio lens and see if there's anything concerning to her and if a person needs genetic testing. The reason why we don't just order, cardio and cancer all together is because they have very different implications if they're positive or negative, and the screening looks very different. And honestly, it'd be a pretty long discussion up front
Right.
if we ordered all of that.
So that's a whole separate test, cardiac.
Yes, and we usually use different labs for that. It just depends on what her
I
analysis
think my
is.
dad had AFib, and my sister has something, and my uncle had AFib also, my
Yeah.
brother. And so I just don't know how genetically predisposed I am for that.
Exactly. In the same way that there's red flags to me, there's red flags to her, that she looks at a family history and she's like, "Ooh, no, we need to look more into this," or, "Oh no, that's totally typical."
I should make an appointment when my sister's in town. She lives in California, and she's going to be in for my nephew's wedding. this
Yeah.
summer. We should come in because she
We have people come in
remembers
together.
everybody's medical history, and she's microbiologist. So
Yes.
She knows all this. We should come in together and answer questions.
We do sibling appointments all the time. It's actually very helpful. We get a lot of good information from, one person knows this side better or whatever. So
Well, that sounds good.
Yeah.
All right, and then as far as just coming in for an appointment, is that considered an office visit that we're billed for? How does that
Yes.
work?
So there's two separate bills, technically. The first one is the genetic counseling visit, and that's just billed like a typical, PCP appointment.
Okay,
And then the second one is the genetic testing itself, which is billed through the lab.
okay,
So that $250 price, that max price, that one's through the lab.
okay. And then, what does an office visit run? I don't know if I'd want to run that through my insurance. It would go to my deductible anyway, so
Yeah.
I'll just cash pay it.
Most people do run it through. I'm not positive though on the exact cost of it because we don't
Okay.
typically see that side of it.
Okay. I just was wondering because I don't want to send any flags to my insurance company.
Sure.
Why are you going in for genetic counseling?
Well, if you do have a reason to do it and we can prove that, then you can qualify for it.
Well, they're always looking for an excuse to raise your rates. So.
Sure. But we have those protections, of course.
Okay.
So they can't be raising your rates for genetic
But if
positive
I
result.
but if I came in for a visit, it would be coded as a genetic visit, right?
Yeah, but often, let's say if an insurance company is going to cover genetic testing, they often require a pre-test counseling visit. So it usually is something that they want to see because they want to see those clinic notes that we talk through your family history and that you do need testing.
Okay. All right, well, I'll give it some thought.
Sure.
I think it would be-
Absolutely.
And there's no guarantee that if you do test positive for the gene that you're actually going to get it, right?
No, exactly. We just know that you could be at increased risk compared to the general population, and because of that, we want to make sure we're offering you screening to compensate for that.
And you had said, it could be minimized based on your lifestyle, so any thoughts or recommendations there?
Well, there's different factors, so we always just want to make sure that we're decreasing the chance of having an acquired mutation, because that's how, if a person has a predisposition and then they acquire a second mutation, that's how a cancer can form. So if we can decrease that mutation rate, and that's just going to be, your typical balanced lifestyle, eating healthy and working out and being active, decreasing any exposures like smoking, things like that.
Is there anything that would contribute to an acquired gene for pancreatic cancer?
So sometimes things like pancreatitis, like if a person has chronic pancreatitis, we know that can be a predisposition
Okay.
to pancreatic cancer. But more so the environmental or acquired ones I'm not as familiar with. Plus, it's very hard to narrow down what caused an acquired mutation or a sporadic mutation. Was it just age? Was it just chance? Was it truly something environmental? It's difficult to tell. That's why usually the next step is making sure we rule out the hereditary causes.
I see. Okay. Well, thank you so much. I
Of
appreciate
course.
it. Do you have a card?
I actually don't have any, but I could give you my number, or you can have that scheduling number.
Could you give
Whatever
us
one.
the number one more time?
Sure. So that is 513-853-GENE, which is 4363.
Awesome. Thanks so much.
Of course.